All right, let's talk about common arterial trunk, double outlet right ventricle, transposition of the great arteries, and corrected transposition of the great arteries. Let's start with chapter 35, which is common arterial trunk. And you may know this already, but common arterial trunk, CAT, is also truncus arteriosus. Same thing. When you have a common arterial trunk, basically there is a single outflow tract for everything: systemic, pulmonary, and coronary circulations. Now, the embryology of a common arterial trunk is failure of septation. So typically, the conotruncal area, the kind of the top of the primitive heart tube, um, needs to undergo, well, one, septation, meaning instead of single lumen, two lumens, and it needs to rotate from off of its right ventricular location to both. And that failure of septation is the problem here with common arterial trunk. Now, there are different types of common arterial trunk, and type 1, also in another classification, A1, is the one that you see there, is the first picture, which is immediately after this common arterial trunk arises from the heart, the pulmonary artery branches off from that. And then it in turn branches into a right and left pulmonary artery. Actually, the two most common are the pulmonary artery branching off immediately and then splitting into the right and left branch pulmonary arteries. But the other one is where the pulmonary artery does split off first, but it supplies the descending aorta and left subclavian artery because there is a ductus. The first one, there is no ductus. The second one, there is a ductus. And the split is right after the second head vessel. All right, where does it arise? Well, it straddles a ventricular septal defect. It's biventricular, meaning that it really arises from both ventricles. It's pretty much straddling the septum pretty evenly. Sometimes it is a little bit coming from the right mostly, but very rarely does it only come from the left. Well, the way that it's diagnosed is, first off, there is a large vessel overriding the septum. That, combined with an absence of a separate pulmonary artery, points you toward common arterial trunk. Now, the common arterial trunk, the root is very large, and if it has a valve, which it often does, the leaflets are thick. They're dysplastic. The actual valve doesn't work all that well. And here's some pictures of dysplastic truncal valves. So you'll see that they're thickened. You can see them in systole. And it's a common characteristic of a common arterial trunk, which is it's got a conotruncal valve, but it doesn't work very well. Sometimes one of the things you can see is the truncal valve that has 4 cusps instead of the typical 3. Now, the truncal valve, basically, because it is dysplastic, it does not function very well. And its main role was supposed to be for keeping blood from sliding back into the heart. Well, this conotruncal valve is not competent, and you do see regurgitation of this valve. Here's some spectral Doppler of the same thing, where you can see kind of that to and fro flow, and the reverse flow is very high velocity. So, what associated findings? Well, not surprisingly, there are aortic arch abnormalities. So right-sided aortic arch, interrupted aortic arch. You can also see something that just happens to be nearby, which is a persistent left superior vena cava. Now, some associated causal findings include trisomies. They're just about involved in all these diagnoses. Also, microdeletions, and the most common one is the 22q deletion, and it's as high as 30 to 40%. And also diabetes. Diabetes really puts you at risk for all sorts of congenital heart disease. So the summary at the end of the chapter is the thing that prompts you to think about this is a ventricular septal defect with a large overriding great artery. You can see that in several other things as well, but if you see a very large vessel and it's overriding the septum, think of a common arterial trunk. All right, next we've got double outlet right ventricle. And in this situation, both great arteries arise predominantly from the right ventricle. Both the pulmonary artery and the aorta are more than 50% positioned over the right ventricle. So, incidentally, because you have that straddling, you lose your aortic mitral continuity. If there isn't that septo-aortic continuity, you lose your mitral continuity as well. As we said, the outflow tracts normally undergo rotation of the conus from over the right ventricle to over both of them, and there's also a septation of the conus. And we just said that the failure of septation leads to common arterial trunk. Failure of rotation leads to double outlet right ventricle. Now, the general structure is you've got both vessels over the right ventricle primarily. You can have a little bit over the left, but more than 50% of each is over the ventricular septum. Now, there also is a ventricular septal defect. Now, there's some overlap, as you can imagine. So when we're thinking about abnormalities of septation, we know that if it's a problem with septation of the great vessels, the problem is common arterial trunk. If the problem is septation of the ventricles, the problem is VSDs. And then when it comes to rotation, you can have an abnormal great vessel arrangement in double outlet right ventricle and transposition, which we will be getting to shortly. All right, so when it comes to double outlet right ventricle, what's the goal? What additional things besides making the diagnosis are we interested in? Well, really, the important anatomy is what is the relationship of the great vessels to each other, and also what is the location of the ventricular septal defect. So that's not too surprising. If double outlet right ventricle is abnormally arranged great vessels in the presence of a VSD, and they're not all the same, well, you have to describe which one you ended up with. All right, so when we're talking about relationship of great vessels to each other, what is that relationship? Well, first of all, they are frequently parallel, with frequently the aorta being on the right. In terms of the ventricular septal defects, they can be subaortic, subpulmonary, doubly committed, and double outlet right ventricle with a remote VSD. Now here's just some practice pictures. You can see that you've got a pretty normal four-chamber view followed by an oblique view where you can get these parallel outflow tracts, and they're both coming from the right ventricle. Here are some more to practice. Normal 4-chamber. Got your 5-chamber view where you can see some overriding. And then finally you can see the aorta and pulmonary artery both coming out of the right ventricle. And the aorta is on the right, pulmonary is on the left. A couple more pictures of the outflow tract basically bifurcating after, actually no. I shouldn't say bifurcating. Let's go with just 2 outflow tracts coming out of the right ventricle. All right, and the aorta typically to the right. Now, as you know, very rarely do these diagnoses come all by themselves. They're frequently associated with other things. So what's associated with a double outlet right ventricle? Well, one is pulmonary stenosis. And just kind of think of it as the aorta sliding over and squishing the pulmonary artery. That's kind of what happens in tetralogy of Fallot. You get an overriding aorta and a narrowed pulmonary artery with varying degrees of obstruction. Think of it this way: as it slides over so much that it's more than 50% over the right ventricle. All right, big surprise, diabetes and 22q, as well as chromosomal. That triad seems to appear in just about everything. So the summary at the end is basically overriding great vessel and a ventricular septal defect. That's exactly what we said in the last chapter, which was common arterial trunk. But the difference between those is one is there is a separate aorta and pulmonary artery. And as long as the great vessels are both over the right ventricle more than 50%, that would count as double outlet right ventricle. All right, transposition of the great arteries. All right. Well, the definition of transposition of the great arteries is ventriculo-arterial discordance, meaning instead of the aorta hooking up to the left ventricle and the pulmonary hooking up to the right, they are switched, with the aorta hooking up to the morphologic right ventricle. Now, and the atrioventricular concordance they're talking about is the right atrium, the morphologic right atrium, does hook up to the morphologic right ventricle like it's supposed to. And left goes to left like it's supposed to. Now, 88% of the time, this transposition is going to be with the aorta being anterior. And that's considered dexter, or the normal de-looping goes on in embryology with the aorta anterior and to the right dexter. Well, the consequences of this rearrangement is that the left ventricle goes out the pulmonary artery instead of the aorta. It goes to the pulmonary artery, then to the lungs, then to the pulmonary veins, then to the left atrium, and then right back to the left ventricle. So that is a basic circle, only involving the lungs and nothing else. So you've got your systemic circulation over on the right side, just kind of doing its own circle, and the left handling the pulmonary circulation in a circle. And that's not a huge deal in fetal life because there is shunting at the level of the foramen ovale and ductus arteriosus. So the oxygenated blood can mix with the unoxygenated blood enough for the fetus to survive. But afterwards, when those shunts close, you get cyanosis. All right, what do you think the four-chamber view looks like? Yes, it is normal. And the five-chamber view, what do you think about that? What's that going to look like? Well, in the five-chamber view, what looks like the left ventricular outflow tract, you'll notice it bifurcates. And very often the left pulmonary artery jumps right out at you. Now, if you want to see the parallel outflow tracts, you need to be a little more oblique, kind of angling from the baby's right shoulder to the left iliac. Now, up in the three-vessel trachea view, what you're going to see is an unusual thing, and it is called the reversed boomerang sign. So let's review our findings. We've got a normal four-chamber. We've got a five-chamber where the outflow tract bifurcates. Up at the three-vessel trachea view, we have basically a single vessel. And if you take an oblique longitudinal view of the great vessels, you're going to see that they are parallel. So if you see parallel outflow tracts, think of either transposition of the great arteries or double outlet right ventricle. Now, up in that three-vessel trachea view, typically you will see only one vessel, and it could be that curve, that reverse boomerang sign, or it can potentially even be straight. Now, at the three-vessel view, the outflow tracts can look almost normal. But even though the picture at right shows two outflow tracts that are converging, very often it's just a single vessel that you see up at that level. So what's the differential diagnosis? Well, both double outlet right ventricle and transposition of the great arteries lack crossover. Normally, the pulmonary artery crosses the crux of the heart, and the left ventricular outflow tract crosses the crux. But in this case, they do not have the crossover. So lacking crossover, you're thinking of double outlet right ventricle or transposition of the great vessels. So the thing that kind of tips you off to transposition of the great arteries very often after just seeing a normal four-chamber view is you go to the LVOT and you see that the LVOT branches. So that's probably the main finding you see with transposition of the great arteries, which is the LVOT branches, suggesting that it's not actually the aorta, that it is the pulmonary artery. All right, now let's talk a little bit about corrected transposition of the great arteries. So corrected TGA or CTGA is also called congenitally corrected TGA, meaning that you had your ventriculo-arterial concordance causing a problem, but then you went and switched the relationship to the atria also, and it's all corrected. So for corrected TGA, you have ventriculo-arterial discordance, and atrioventricular discordance. So in other words, you've got two wrongs, and two wrongs do make a right. So it's basically fixed itself. The aortic arrangement or the vessel arrangement, again, the aorta is anterior, but now it's to the left of the pulmonary artery. It's also why it was called LTGA previously. Well, you've got abnormal L looping this time, causing the aorta to be to the front and to the left. Now, in a normal fetus, here's an example of atrioventricular concordance. You know, they've got the moderator band pointed there in the cartoon. It's not particularly obvious in the photograph, but that's the whole point, is you have the morphologic right ventricle, and it's going to be hooked up to the pulmonary artery. All right. So in a fetus with TGA, corrected TGA, we said there's atrioventricular discordance. And that discordance is what kind of fixed the whole thing, that congenitally corrected the whole thing. So what we've got is we have a we have a left atrium, morphologic left atrium, and kind of the way we can tell is because the pulmonary arteries drain into it, pulmonary veins drain into it. So we've got an atrium with pulmonary veins, and that particular left atrium is hooking up to a ventricle with a moderator band. So that is left atrium to right ventricle. So that is atrioventricular discordance, which cancels out the ventriculo-arterial concordance. Here's some pictures where you can see the discordance. You can see the posterior ventricle has a moderator band, suggesting that the morphologic right ventricle is hooked up to the morphologic left atrium. In the 5-chamber view, you can see this ventriculo-arterial discordance. In other words, you've got the morphologic left ventricle hooked up to an outflow tract with a bifurcation. In the 3-vessel trachea view, there's often a single vessel, just like in transposition of the great arteries. But in the congenitally corrected form, there is a big space between the aorta and the SVC. All right, here's some more examples of how far away the SVC is from the aorta. Typically, a 3-vessel trachea view that includes the aorta has this SVC right next to it. TGA can occur with dextrocardia. Of course it can. Everything seems to be in every possible way it can be, just to mess things up. And what's the prognosis for congenitally corrected? Well, the reason that it's good if it's isolated is that it is already fixed. But the problem is a lot of times it is not isolated. All right, well, here's the summary slide. And you've got an abnormal 4-chamber view. What's abnormal about it? There's atrioventricular discordance. So if you look at the 4-chamber view, you will see that the morphologic right atrium does not hook up to the morphologic right ventricle with a moderator band. It hooks up to the other one. And that's it for today, folks.